We are live.
A very good evening, everyone, on a nice Sunday evening, and we welcome you all to AIOS Guru Sangam. Guru Sangam basically means bringing together masters in ophthalmology to share insights, innovations, and experiences. Guru, we all know, signifies the revered teachers, and Sangam refers to the meeting point of knowledge and expertise in this case. So, I welcome you all to the session 17 of Oculoplasty and the general segment. And today we are covering very important topics, which are the most general in terms of oculoplasty. So let's please come along and join the faculty and the expert panelists for an insightful session with lectures on key topics. So to enhance our knowledge, educate, elevate, and excel, we thank the AIS dignitaries, Dr. Partha Biswas sir, the President AIOS, Dr. Santosh Vanava sir, Honorary General Secretary, and Dr. Manoj Chandra Mathur sir, Honorary Treasurer, along with the entire team for organizing these sessions and giving it wings. Our speakers for the day are Dr. Miriam Pauly from Girdhar Eye Institute, Kochi, Dr. Inder Mohan Rustagi from World College of Medical Sciences, Jharjhar, and Dr. Arundhati Pandey from SMCW, Pune. We also have our expert panel consisting of Dr. Modini Pandarpurkar from Sarojini Devi Eye Hospital, Hyderabad, Dr. Preeti Uday from DRR Eye Care Oculoplasty Hospital, Chennai, and Dr. Roshni Gupta ma'am from Bangalore. The topics for the day include anatomy of eyelid, ocular anesthesia, and entropion. And if you ask me, these are the most important topics which happen nearly in every college and every hospital as well. And I am thankful for Dr. Farnaz for joining me for co-moderating this session from Center for Sight, Hyderabad, and myself, Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur. So over to our first speaker, Dr. Marion Pauly ma'am, for anatomy of eyelid.
Hi, good evening all. Thank AOS for giving me this opportunity. So let me share my screen.
Yes, ma'am.
I think the screen is visible now.
Yes, ma'am. Hmm.
Okay. Yeah. So let us start. We know eyelids are mobile tissue curtains, as we see in this video, and protects the eyes from injuries and excessive light, spreads the tear film over cornea and conjunctiva, helps in restoration of preocular tear film with each blink, and most of all, it contributes very important to the facial features of a person. So start with embryology. Eyelids are formed by the reduplication of surface ectoderm above and below the cornea during the second month of gestation. The folds enlarge and their margins meet and fuse with each other at the end of third month. So the lids separate by seventh month of intrauterine life. The folds contain some mesodermal tissues, and that is for the development of muscles. Connective tissue and tarsal plate are formed from the mesenchymal core. And the most important muscle, that's the orbicularis oculi muscle, is developed from the mesenchyme of second pharyngeal arch. So the tarsal glands are formed by the ingrowth of columns of ectodermal cells from the lid margin. Then eyelashes develop from as epithelial buds from lid margins. Glands of mole and sieves are from ciliary follicles. So this is in short about the embryology. So there are ectodermal element and the mesodermal element in the eyelid. So now coming to the few congenital anomalies, coloboma, when eyelid development is incomplete due to either failure of migration of ectoderm or due to some mechanical force such as amniotic band on the eyelid folds. Second is cryptophthalmos. This is an anomaly where the eyelids are absent and replaced by continuous layer of skin, as you can see in this picture. This is due to the failure of eyelid fold formation. Then third one is microblepharon, where the small eyelids usually associated with the anophthalmos. Ablepharon is absence of eyelids. Euroblepharon is an interesting condition where there is enlargement of horizontal palpebral apertures and is associated with the lateral ectropia. In epiblepharon, you can see in this picture, the lower lid pre-tarsal muscle and skin right above the lower lid margin to form a horizontal fold of tissue. Whereas in congenital entropion, it can be as a part of microphthalmos in upper eyelid, or in the lower eyelid, it is due to the mild development of inferior retractor aponeurosis. Regarding the retractors, we will come later. Then you can have congenital upper eyelid eversion also. So now look at the extent of the eyelid. So, there's an upper eyelid and a lower eyelid. The upper eyelid extends over eyelid margin to the eyebrow, and the lower eyelid is smoothened into and merged with the skin of the cheek, where nasojugal and malar crease may limit it. The upper eyelid covers around 2 millimeters of the cornea, and the lower eyelid just touches the inferior limbus. Coming to the lid folds and crease, there is a superior lid crease 6 to 8 millimeter above the eyelid, above the edge of the eyelid. This can vary with the sex. In males, it is around 6 to 8 millimeter, whereas in females, it is around 9 to 11 millimeter. It's formed by the slip arising from the tendon of levator palpebrae superioris muscle. Inferior lid fold is formed by the slip that arises from the fascia of inferior rectus muscle. Two other folds are in the lower eyelid, nasojugal fold medially and malar fold laterally. Now, what is the relevance of this? Nasojugal fold and malar fold are the line of junction between the skin and the denser tissue of cheeks, therefore limit the blood or fluid downwards from eyelid to the cheek. Second, superior lid fold or lid crease serves as a hidden landmark for various eyelid surgeries such as ptosis, blepharoplasty, and all the minimally invasive approaches to the orbit. Superior lid fold, it is absent or less formed in congenital ptosis, as you can see in this picture. This is the lid crease incision is done for ptosis surgery. Now coming to the canthi, there is a lateral canthus and a medial canthus. So as you can see in this picture, lateral canthus, it is acute and makes an angle of around 30 to 40 degrees. It is 5 to 7 millimeter medial to the orbital margin and 1 centimeter from the frontosigmoidic suture, and it lies in contact with the eyeball. Now look at the medial canthus. It's more obtuse compared to the lateral and separated from the globe by lacus lacrimalis. Caruncle and plica semilunaris are present here. The palpebral fissure is 9 to 11 millimeter in height, and it is 28 to 30 millimeter wide and can be asymmetrical also. So blepharophimosis is a condition where the extent of the palpebral fissure is reduced. Now, coming to few applied anatomy conditions, that is epicanthus means a vertical fold of skin around medial canthus. So there are various types of epicanthus. So epicanthus superciliaris extend from just below the eyebrow to an area just above the inferior orbital rim, usually obscuring the caruncle, as you see in this picture. Then epicanthus palpebralis. So palpebralis includes both the lids. So it extends from the medial aspect of the upper eyelid to the medial aspect of the lower eyelid. Then epicanthus tarsalis. So it's a fold begins laterally and extends over the entire eyelid, ending at the medial canthus. Then epicanthus inversus, it is similar to tarsalis, but it involves the lower eyelid. So as the name indicates, the extent also is indicated by its name. Coming to telecanthus, it's abnormally wide canthae, whereas there is an increase in the size of the medial palpebral ligament, while the interpupillary distance is normal. Blepharophimosis epicanthus syndrome is a complex eyelid malformation where you can get blepharophimosis, then ptosis, then epicanthus inversus with the poor levator function, and a telecanthus. So can they determine the slant of the eyelid? So there are various racial variations. Mongoloid, anti-mongoloid slant can be seen. Now coming to the palpebral margins. It is 2 millimeter wide. As you can see, it extends from anterior margin to posterior margin. Each eyelid margin is divided into two parts, medial and lateral, by the lacrimal papillae with punctum at its center. So medially, the lacrimal portion is devoid of lashes. So it's called the lacrimal portion, and laterally it is with the lashes, thus that is called ciliary part. So there is a lacrimal part as well as a ciliary part. The anterior margin is rounded and the posterior margin is sharp with intermarginal strip in between. Gray line is the pretarsal portion of orbicularis that run along the lid margin and divides the lid margin into anterior and posterior lamellae. The applied anatomy is gray line corresponds to the avascular plane of the lid, and we can split the lid at gray line into anterior and posterior lamella in various eyelid surgeries. Symplepharon is a condition in which the eyelid is adherent to the eyeball as a result of addition between the palpebral and the bulbar conjunctiva. Ankyloblepharon is a condition where additions between the margins of upper and lower eyelid. So now come to the cilia. Cilia arranged in 2 to 3 rows and more in upper eyelid. In upper eyelid around 100 to 150. It is forward, upward and backward. In lower eyelid around 50 to 75 in number. It is forward, downward and backward. So no erector muscle, only sensory innervation is present. So trichiasis, as we know, this is acquired misdirection of lashes with normal position of the eyelid. Pseudotrichiasis is seen with entropion. Madarosis, there is a decreased number of eyelashes. Then lash poliosis, where there is premature graying of the lashes. Trichomegaly, there is excessive lash growth. So nowadays, it can be seen with anti-glaucoma medications. Then this trichiasis, in this picture, you can see an extra row of lashes. So now let us move to the structure of eyelid. So eyelid has skin, then subcutaneous areolar tissue, striated muscle, then submuscular areolar tissue, tarsal plates and fibrous tissue, non-striated muscle and conjunctiva. Let us see each one by one. So skin is thinnest in the body and highly elastic. So it recovers easily from, it becomes edematous very fast and similarly recovers easily from edema. All layers of skin are well developed with the epidermis being stratified squamous epithelium. Basal layer of epidermis has numerous typical eccrine sweat glands and unicellular sebaceous glands. So this is relevant as various sweat gland tumors and eccrine and both apocrine tumors can develop from the eyelid skin. The dermis is rich with network of elastic fibers, blood vessels and lymphatics. And the interesting thing is it has got variable number of melanocytes whose production increases with edema and inflammation. So this is important as some patients can have periocular darkening, dark discoloration of the skin following chronic edema or even otherwise. This is due to the variable number of melanocytes. The orbital skin is attached to the orbital margins and palpebral ligaments, especially on the medial aspect. Now look at the subcutaneous areolar tissue. The areolar tissue is very loose and no fat, and it is absent near the ciliary margin. So in this picture, you can see the whole lid is edematous, but near the lid, it is less. It's absent near the ciliary margin, lid fold, and at canthi where skin is adherent to the ligaments. Applied anatomy is due to absence of fat, fluid from any edema or any bleeding engorges this layer and produce swelling of eyelids. Now coming to the striated muscles, it includes orbicularis oculi and levator palpebrae superioris in the upper eyelid. So now let us look at the orbicularis. Orbicularis has got two parts, orbital part and the palpebral part. Palpebral part is again divided into preseptal part and the pretarsal part. Preseptal part is over the septum, pretarsal part is over the tarsus. So now look at the orbital part of orbicularis oculi. It is originating from the upper orbital margin, medial to supraorbital notch. Frontal process of maxillary process of frontal bone and frontal process of maxilla, and anterior part of medial palpebral ligament, lower orbital margin, medial to infraorbital foramen. So this is the origin of orbital part of orbicularis oculi. From the origin, these fibers travel laterally and meet at the lateral palpebral raphe. So again, this has got two parts, that is musculus superciliaris. They are the upper medial fibers of the orbital part, which pass on to the skin of middle part of eyebrow and functions as the depressor of the middle end of eyebrow. Another part is musculus malaris. As the name indicates, it is inferiorly and the fibers are attached to the cheek. The function is closes the lid firmly. The muscle contracts during short, powerful expiration, as in crying, blowing of nose, sneezing, excessive laughter. Contraction of the orbital part depresses the eyebrow to reduce the excessive light from entering, and the palpebral part is relaxed to allow the lids to remain open. It is innervated by the facial nerve through its temporal and zygomatic branches. Now coming to the palpebral part, as we have already discussed, it has got a pretarsal and the preseptal part, and each has got a superficial head and a deep head. Superficial head arises from the medial palpebral ligament, whereas deep head of the pretarsal arises from the lacrimal fascia, whereas deep head of the preseptal arises from the posterior lacrimal crest. So these preseptal fibers pass superiorly and inferiorly in front of the orbital septum and unite at the lateral palpebral raphe. Whereas pretarsal fibers pass laterally and above and below the tarsus to form the lateral palpebral ligament inserted to the lateral tubercle of the vidnal, that is little more posterior to the attachment of the preseptal fibers. So pars lacrimalis is the deep part of the pretarsal portion called as Horner's muscle. Pars ciliaris is the pretarsal fibers that run along the lid margin called as muscle of Rioli. This part has got a big role in the lacrimal pump to determine the tearing function. Now move to the levator palpebrae superioris muscle. It arises from the apex of the orbit, that is from the lesser undersurface of the lesser sphenoid above the annulus ossein. The muscle belly is around 40 millimeter in length and passes below the roof of the orbit till about 1 centimeter behind the septum, from where the levator aponeurosis starts. Aponeurosis is around 15 millimeter long and 30 millimeter wide. The aponeurosis starts from the transverse Vidnal's ligament and forms the medial and the lateral horns. So medial horn passes over the reflected part of superior oblique and gets attached to the medial caudal tendon. Lateral horn divides the lacrimal gland into orbital part and the palpebral part and gets attached to the lateral caudal tendon. So this has got a significance in thyroid eye disease, as you can see a lateral flare. That's a peculiarity of thyroid-related lid retraction due to the inflammation of this part. So Whitnall's ligament, also called superior transverse ligament because it is transverse. So thickened band of orbital fascia formed by the condensation of levator aponeurosis. So levator aponeurosis starts from the Whitnall's ligament. It extends. The extent is trochlear pulley to capsule of the orbital lobe of the lacrimal gland. Primarily, this acts as a suspensory ligament for the upper eyelid and acts as a fulcrum for the levator. Recognition of this ligament is very important during ptosis surgery, as sometimes cutting the ligament can lead to failure of levator function. So the aponeurosis passes to the septum orbital, as I have already discussed, and it passes forward and downward and attaches to, the levator has got multiple attachments. It attaches to the septa between orbicularis muscle. Then few fibers will attach to the skin to form the lid fold. Posterior fibers insert to the anterior surface of the tarsus, that is 3 to 4 millimeter below the superior border. That is the superior half, superior 1/3 of the tarsus, and the superior conjunctival fornix. The nerve supply is by the superior division of oculomotor nerve. Action is the elevator of the upper eyelid, as the name suggests, and it is antagonized by the palpebral part of orbicularis. Applied anatomy, as we know, in third nerve palsy, you can get paralysis. Similarly, in myasthenia gravis, you can also myogenic ptosis can happen. Then in levator aponeurosis dehiscence, you can get deep superior sulcus because the aponeurosis goes deep into the orbit, detaches from the tarsus. Now move to the capsulopalpebral fascia. It is analogous to levator aponeurosis of the upper eyelid. This fascia head from attachments to inferior rectus muscle, originates from the attachments of inferior rectus muscle. It anteriorly divides and encircles the inferior oblique muscle. It has got two parts and joined to form the Lockwood ligament. It inserts into the inferior border of the inferior tarsal plate. So this is the capsular palpebral fascia, and it inserts into the lower part of the inferior tarsus, and you can see it. It is surrounding the inferior oblique muscle. Now move to the submuscular areolar tissue. It lies between orbicularis and tarsal plate and continues with the subaponeurotic stratum of the scalp. So it is important because some of the hematomas can see to the lower eyelid through this space and to the eyelid, upper eyelid through this space. It is traversed by fibers of levator. In the lower eyelid, submuscular tissue lies in a single space in front of the applied anatomy is nerves and vessels, that is peripheral arterial arcade, are present in this space. So local anesthetic must be injected deep to the orbicularis. Coming to the tarsal plate and fibrous tissue, the fibrous tissue is the framework of the eyelids, thick centrally as tarsal plate and thin peripherally as septum orbitae, that is palpebral fascia. So tarsal plate is a very important structure as it maintains the shape of the eyelid. No cartilage, it consists of dense fibrous and some elastic tissue around the tarsal gland. The superior tarsus is crescentic and larger, that is 10 to 11 millimeter at the middle. Whereas in the inferior, it is around 4 to 5 millimeter in height at the middle part of the tarsus. Both upper and lower are around 29 millimeter long. So we have seen the levator aponeurosis is around 30 millimeter long. So as is the length of tarsal plate, around 29 millimeter long. The thickness comes to around 1 millimeter. Now coming to the describing the surfaces of the tarsus, anterior surface is convex and separated from orbicularis vellus areolar tissue, facilitating independent movement. Posterior surface is concave and adherent to conjunctiva. Ends of both the plates are attached to the orbital margin by medial palpebral ligament medially and lateral palpebral ligament laterally. Attachments we have already seen. Superior border of the tarsus, septum and molars muscle and levator aponeurosis. Inferiorly, inferior septum, inferior palpebral muscle and capsular palpebral fascia. The Lockwood ligament acts as a suspensory hammock for the globe, serves as anchor for inferior conjunctival fornix. And capsular palpebral fascia, we have already seen it is analogous to levator aponeurosis and forms Lockwood ligament in the lower eyelid. In spastic entropion can happen due to a disinsertion of capsular palpebral fascia from the tarsus. Now, looking at the various suspensory system of eyelids. So, Whitnall's ligament we have seen, Lockwood ligament we have seen, medial palpebral ligament, lateral palpebral ligament, and eyelid margins. In short, about various structures, medial palpebral ligament, it is triangular in shape, attached to frontal process of maxilla from anterior lacrimal crest till the suture line of frontal process with the nasal bone. The anterior surface of the ligament is adherent to the skin. The base is at the anterior lacrimal crest, where it divides into an anterior part and a posterior part. Posterior part is continuous with the lacrimal fascia, whereas anterior part is divided into upper and lower band. One is in blend with the medial palpebral ligament. Coming to the lateral palpebral ligament, it attached to the Whitnall's tubercle at the lateral orbital margin and medially attached to the lateral end of the tarsal plate. Anterior surface is fused with preciliary fibers of orbicularis, few lobules of lacrimal gland, and lateral palpebral raphe are superficial to this. Posterior surface is separated from the lateral check ligament by lobule of lacrimal gland. Coming to the anatomy, applied anatomy, medial palpebral ligament is very important landmark in lacrimal sac procedures. Any lesion above the medial palpebral ligament is not usually arising from the lacrimal sac. If a sac lesion going above the medial palpebral ligament, then you have to think about lesions, think about malignant lesions. Then the MPL will keep the punctum in position. In Centurion syndrome, the medial palpebral ligament is attached very anteriorly because of the nose, because of the peculiarity of the nose. So in that case, the punctum will be away from the globe, and a young patient can present with chronic epiphora. Is usually bilateral, as you have seen in this picture. The posterior limb of medial palpebral ligament is important in maintaining the position of medial eyelid so that it is well opposed to the globe. So in the treatment of Centurion syndrome, we have to release the medial palpebral ligament so that it will go back to its go near to the globe, leading to decrease in the epiphora. The laxity of medial and palpebral ligament can lead to entropion and ectropion. Coming to the septum orbital, it's a thin membrane of connective tissue taking part in all movements of eyelids. It is thicker and stronger on the lateral aspect compared to the medial aspect. Orbital septum attachments, it is superiorly, it is attached to the upper orbital margin, supraorbital notch, converting into supraorbital foramen in front of the pulley or superior oblique muscle and upper medial angle of orbital bone. Medially, it is deep to posterior lacrimal crest. Inferiorly, inferior orbital margin. The facial aspect of zygomatic bone where it forms an osseo-fibrous pocket known as premarginal recess of Eisler. Laterally, it is attached to the orbital margin in front of lateral palpebral ligament. That is it nostril. Coming to the various, septum is a very important structure in all the periocular surgeries. The important relationships anteriorly loose areolar tissue, posteriorly it is in contact with the orbital fat and separates from the lacrimal gland. The clinical significance is it's a barrier to extravasation of blood and spread of infection. With increasing age, the septum weakens, so the orbital fat behind the septum herniates, along with the thinning of the skin can lead to dermatochalasis. Now move to the fat behind the septum, that is post-septal eyelid fat. It's an anterior extension of extracorneal fat. The septal partitions divide the upper eyelid fat into central fat pad and medial fat pad. In the lower eyelid, there are three fat pads. One is nasal and the central and the lateral fat pad. The nasal and central is separated by inferior oblique muscle, and central and lateral are divided by septal partitions. This anatomy is important, especially in doing blepharoplasty. And it's an important landmark for laceration repairs also. While doing lid laceration repair, if you are incorporating septum, patient can have lack of thalamus. So too, we have to differentiate septum from the levator muscle that is again underneath by a simple test where you can ask the patient to move up and down. The levator will move along with the movements of the globe, whereas septum will not move. Second thing is, when you pull the septum, you can feel a tug. That means the septum is attached to the orbital limb. Whereas levator, once you pull, it will move along with your pull. So the attachment is far behind and at the orbital apex. Another thing is presence of orbital fat in a case of trauma implies rupture of the orbital septum, and in that case you have to rule out injury to levator muscle. Now move to the non-striated muscle. So that is includes palpebral muscular muller just behind the septum. The fibers are derived from the levator muscle in the upper eyelid and inferior rectus in the lower eyelid. The nerve supply is by sympathetic. The applied anatomy is it's an upper eyelid retractor. So in Horner syndrome, it's a triad of meiosis, partial ptosis, and hemiplegic sweating. It is resulting due to sympathetic paralysis. Then in mild ptosis, you can utilize the help of Muller's muscle to correct mild ptosis. Whereas in mild lid retraction, again, Mullerotomy can help in correcting the lid retraction. Conjunctiva, coming to the final layer, there's a mucous membrane lining the eyelids, composed of non-keratinized squamous epithelium. It contains goblet cells, accessory lacrimal glands, that's Wolfram and Crose. Now coming to the various glands, Meibomian glands is a sebaceous gland lying within the tarsal plate. Orifices open just on the lid margin, just anterior to the mucocutaneous junction. It's arranged parallelly, 20 to 30 in each eyelid. And this is the view. There's an you can see the arrangement of the Meibomian gland in both upper and lower eyelid. Glandosis is a modified sebaceous gland. It opened directly to the ciliary follicle. Glands of Morris is modified sweat gland, opens directly to ciliary follicle or sebaceous glandosis. Glands of Wolfram in the upper border of the superior tarsus. Glands of Crose is an accessory lacrimal gland in the subconjunctival space in the fornix. All these glands are important as inflammatory conditions like elesio, then malignancy also can arise from these structures. Coming to the arterial supply, the arterial supply is internal carotid artery, then it goes to the ophthalmic artery, then the lacrimal artery. From ophthalmic artery, medial palpebral artery arises, lacrimal artery, lateral palpebral artery arises. So it forms a marginal arcade that is 2 to 3 millimeters from the lid margin. And this also receives branches in superficial temporal, infraorbital, and transverse facial artery. Now coming to the venous drainage, there is a pre-tarsal venous plexus and a post-tarsal venous plexus. Pre-tarsal venous plexus, they are superficial to tarsus as the name denotes. Laterally, it drains to superficial temporal and lacrimal vein. And it finally drains to external jugular vein. Medially, angular vein and facial vein, and drains to internal jugular vein. Post-tarsal, they are the deep vein that is posterior to the tarsus, drain to ophthalmic veins. Lymphatic drainage, again, superficial plexus and deep plexus, pre-tarsal and post-tarsal. Superficial basically drain the orbicularis and the skin. Medially goes to submandibular lymph nodes, and laterally superficial parotid nodes. Whereas in the deep tarsal, post-tarsal plexus, drain tarsal plate and conjunctiva. Medially, it again goes to submandibular, and laterally it goes to the deep parotid nodes. All these are important in malignancies and other infective and inflammatory conditions. Coming to the nerve supply, the knowledge is very important. It has got a motor supply and a nerve sensory supply. Motor supply is by the facial nerve and the oculomotor nerve. Facial nerve supplies orbicularis oculi, and oculomotor nerve supplies the levator muscle. Sensory is by the in the upper eyelid, supratrochlear, infratrochlear, laterally, lacrimal branches of ophthalmic nerve. Lower eyelid, infraorbital, lacrimal nerve, infratrochlear nerve. And sympathetic supplies the Muller's muscle. So this knowledge is important, especially in various nerve blocks. Facial nerve block can be given in the upper eyelid and the lower eyelid. DCR anesthesia blocks infraorbital and the infratrochlear nerves. Then various local infiltration can be given for various eyelid surgeries. So this is in short about the anatomy of the eyelid, which grossly covers the various structures, nerve supply, lymphatic drainage, and the vascular supply. Thank you so much.
Thank you so much, ma'am. It was an extensive coverage regarding the anatomy of the eyelid. And I think this is the basis on which all the oculoplasty surgeries go on. And also, it's a very important part of Viva as well. So I'll just request Dr. Preeti, ma'am, any comments?
Yeah, very nice talk, Marian. It was really extensive.
You need 2-3 hours to really learn the anatomy of, teach the anatomy of eyelid.
What I want to tell everybody today is that we still read anatomy. So it is something, it's an ongoing process, and still after so many years of practice, I go through the anatomy before surgery. So every time you read anatomy, you will find some new point. You will see it in a different aspect every time. Now, few things I like to reiterate, Marian has already explained. One is that difference between epiblepharon and entropion. Many a times we get patients referred, they are small children, and you are not able to see the lid margin very nicely because there is an extra fold of skin, which is actually an epiblepharon and not an entropion. So what you need to see is that lid margin. If the lid margin is in its place, but there is an extra fold of skin, then it is an epiblephron. And that usually the child outgrows it when the cheek the cheek fat reduces, then epiblephron gets corrected by itself. And usually the hair that is there, which is rubbing on the cornea, is very fine. They do not cause much redness or irritation. It's only lubricants that you can give. Or temporarily, you can give fillers for these children so that this lid fold doesn't touch on the eye. So remember to distinguish and learn to distinguish between epiblephron and entropion, which is very important. Next, I thought in the orbicularis part, she has beautifully described the different parts of orbicularis. It is very important for you to know correct anatomy, especially when you're giving Botox, you're giving all these aesthetic products, because you need to know exactly which fibers you're going to inject and which fibers are affected in various conditions, also which fibers are causing the wrinkles in aesthetics. So where exactly we give the Botox and why do we give it on pretarsal, why you don't give it on the preseptal, these kind of small points are important because that's why you need to know the different portions of the orbicularis. Also in facial palsy, when the orbicularis is thinned out, you need to be careful when you're doing gold weight, etc., because you don't have much cover. The muscle has thinned out. And also it is one of the causes of atonic sac. So the lacrimal pump is affected. The fibers which go onto the lacrimal sac, they are not functioning and the sac remains dilated. And that atonic sac is also a very common problem of and cause of epiphora in patients even with trauma. They have damaged orbicularis in these cases and you can get watering in spite of a patent syringing. Okay. And also, I would like to emphasize on the fact that lower eyelid position is held in place by the posterior limb of the MCT and not the anterior limb. So many of the students ask me that when you're cutting the anterior limb of the MCT during DCR, should we reattach it? Usually, when your anterior limb is cut, your lid will not have any malposition. Only when the posterior limb is cut, you will have a lid malpositioning, and that's when you need to reattach the MCT. Also, I think she covered on the fat bags or the fat pads in the eyelid. So pre-aponeurotic fat is a very, very important landmark for you to recognize the levator muscle. So just behind or just posterior to the pre-aponeurotic fat will be your levator muscle. During surgery, when you're learning to do a dissection, you will not be able to recognize levator very comfortably. Whenever you see fat, you know that the structure which is posterior to that is the levator muscle. Also in trauma, if you see the fat coming out, when there is an eyelid laceration, you know that the septum is breached. And then you need to also evaluate correctly if there is any levator laceration. You do not have to close the septum in case of eyelid trauma, okay? You can just close the rest of the layers of the eyelid, but not the septum. Otherwise, you will get severe lagophthalmos. I think that's about it. Any other questions? If anybody has got, we could maybe take those.
Okay. So there is one question, ma'am, from the audience. So in case of resurgery during levator surgery, like ptosis surgery, what do you expect anatomy-wise?
Yes. Marian, you want to take that question?
See, anatomy-wise, anatomy might not change because you can find out the levator even in resurgeries. Always go by layer by layer. And if you are very, like, you are really finding it difficult, you can dissect a little more up. And to find out, then you come anterior.
Yeah.
Because too much of scarring, no, it happens with mostly with traumatic ptosis, if it is. Traumatic ptosis, the whole structures are like totally distorted. So in that case, you'll find it very difficult. But otherwise, anatomy-wise, skin, subcutaneous tissue, then orbicularis, then you can trace the levator, open the septum, open the fat pad, you can see levator down.
Yeah, so I think what maybe you're asking is that you've already resected, so levator will be shortened in this cases. And sometimes you need to do a hang back if you don't have enough levator and you have overcorrected. Okay, but usually you will find it. There will be scarring, of course. But if you go layer by layer, like Marian said, you will be able to find all the layers.
Right.
I'll just add one point. Like, I mean, since we are all probably way early in the career as compared to all the expert panelists and speakers here, I think what I find myself doing when I'm operating is that when I'm looking at the face, there is a part of me which is doing a complete scanning. Like, I don't know why, but I can actually scan it, and I'm imagining the anatomy underneath the skin layers. So it's that important. And as ma'am said, that every single surgery you do, the anatomy has to be kept in mind. So you should be able to scan the patient from like the skin to muscles to bones when you're operating. And then after that, remember that there can be anomalies as well. So what you expect and what you actually see might also be slightly different. So you have to keep the anomalies in mind.
I think the eyes see what the mind knows. So
Mhm.
initially, when you're just assisting, you will see everything red and you will not be able to recognize various tissue except fat, which is looking like yellow. But slowly, as the eye gets trained, you will be able to recognize each tissue. It is exactly like how the books describe the anatomy. So it's a good idea to do some dissection courses, which will help you to learn the different layers, especially the fresh cadaver dissection courses.
In this aspect, I actually follow Dr. Santosh Ranavasa. He says, when the color changes, the tissue level changes. That is exactly correct.
Yeah,
To recognize the hues of the color, you will have to see it more often. Okay,
yeah,
any
we
other questions from the audience? Audience interacting?
I think that's about it. We have the questions for this session, and we can go to our next talk, and that would be by Dr. Inder Mohan Rastagi, sir, on ocular anesthesia. Thank you, Marian ma'am, for giving us the best briefing of eyelid anatomy. And I think it's there for the records now. So I think the postgraduates can, and even the general
Practicing.
ophthalmologists or specialists can revise it again and again. Thank you so much, ma'am.
Thank you.
And before sir begins, I would just say that this is the other topic which is extremely important, which often goes wrong. And you should have the anesthesia in your hands, and so that you know you're not getting the edema when you're trying to operate. So over to you, sir. So you're muted, sir.
Yeah. Thank you, Dr. Alika. Am I audible?
Yes.
Yeah. I'm really thankful to the president and executive body of the IIS and of course, Dr. Santosh Ranavasa sir and you that I have been allotted this topic for ocular anesthesia.
So you can click on the slide once and then it will move forward. One click on the slide and it will move, sir. Yes, sir. Perfect, sir.
So basically, it comprises of the something about the anatomy, then of course the mix of the anesthesia and the medication and the various blocks. So the objective of the anesthesia in intraocular surgeries is that we have to have an akinesia of the globe and the eyelids. Then we have to have a proper anesthesia of the globe, eyelids and adnexa. And of course, along with this, we have to have a relaxed patient. And after this, we want to avoid any untoward reaction. So all these things mixed with post-operative analgesia, that would be an ideal anesthesia. So before going into that, there are a few anatomical quadrants of the globe and orbit. There are 4 quadrants, that is supranasal, supratemporal, infranasal, and infratemporal. So infratemporal space is the largest and the least vascular, which is the preferred quadrant for modern retrobulbar and single shot peribulbar blocks. And supranasal quadrant is quite vascular, but contains anterior ethmoidal nerve And usually in oculoplastic procedures, this quadrant is preferred. And infraquadrant and infranasal quadrant is most popular for subtenon nerve blocks. So anatomy is basically the orbit is a square pyramid with this having apex posterior and base corresponding to anterior aperture. Orbital axis is slightly oblique laterally and anteriorly, as the lateral wall is at a 45-degree from the sagittal medial wall. At the same time, orbital axis is slightly ascending anteriorly, as the orbital floor being horizontal and roof has a 30-degree angle. So it is a little bit, pyramid shape, and the rim is again oblique inferiorly and laterally. So this is how the things work. There is a difference between the orbital and visual axis. Visual axis is straight and variable where the eye is looking, and orbital axis is fixed, and it is usually at the 45-degree. So another thing is the length. This is about the shape. Another thing is the length. Length of the orbit is 40 mm, and it is the orbit is almost pear-shaped, having its largest horizontal vertical diameter. They are around 1 centimeter from the orbital rim. And the globe, the orbital volume is 25 to 30 cc, and overall orbital volume. And out of this, the globe occupies 7 cc. There are 7 bones which are forming the orbit, and we should know about this. So the clinical significance of the pyramidal shape of the bony orbit is basically how the needle has to go, and what are the risk of the complications like perforation and nerve damage, and then of course the efficacy of the block. The wall, medial wall is the thinnest bone, and it is almost most of the time vulnerable to perforation and potential spread of infection from the sinuses. So that is to be taken care of. And another thing is that we have already told that most vital neurovascular structures, they are concentrated in the orbital apex and within the muscle cone, where we target for the retrobulbar blocks. Another thing is the concentration is the needle longer than 31, because the overall length is almost 40 mm. So they are more than 30 mm, they are avoided to reduce the risk of the deep injuries. And that is why while giving anesthesia with a long needle, it is possible to reach the apex of the orbit to enter the skull and to inject directly into the CSF. So if you take longer needle, that is another danger. And then of course the patient positioning, patient primary gaze is recommended over older techniques that look you up and down or look up and in, because it if the patient is looking straight, that keeps the optic nerve and vessels in a less vulnerable position. So these are the few injection sites. That is, medial aspect is considered relatively safer area, and because of that, the fat field space between the globe and the medial wall, they are avoided in this region. Supranasal quadrant is avoided because of the proximity of the ophthalmic artery, and natural contour and of the angle, they have to be taken care while we are going to the injecting the needle, so that the needle goes directly parallel to the orbital floor, which avoids the help in avoiding the damage. So these are the 4 quadrant, and usually the infranasal quadrant is chosen for the subtenon block, supranasal for the oculoplastic, and of course supratemporal is the most common one. The infratemporal is the most common one. So overall length, here it is showing that around 40-45 mm, and we have to take needle according to that. And another thing is that if we go oblique approach, then we can damage the globe also. So the patient looks straight, and then we can take give the block. Another important thing is that there are 3 major landmarks, that is superior orbital fissure, inferior orbital fissure, and optic canal. And these are few important structure in the superior orbital fissure, and it is 22 mm length, and it is divided into supralateral, inframedial section. And these are the important nerve into this, that is inframedial segment. There is a oculomotor foramina, which is surrounded by the annulus gin, and it is having oculomotor nerve, abducens nerve, sympathetic fiber, nasociliary nerve, and terminal branch of the trigeminal nerve. So another part is inferior orbital fissure. Here it contains the maxillary branch of the trigeminal nerve and zygomatic nerve, and few parasympathetic fibers. Third is optic foramen, which is having optic nerve and ophthalmic artery. So that is how the clinical anatomy is important. Another part while giving the block is annulus of Jin, because it is formed by the muscles, extraocular muscles, and that is to be taken care of. So this intracorneal compartment of the orbit is having all these things, that is optic nerve, artery, third cranial nerve, sixth cranial nerve, nasociliary nerve, and ciliary ganglion. Here it is the ciliary ganglion, which is immobilized, the given block in the retrobulbar block, and it is almost 1 centimeter behind the orbit's rear rays. Another thing is that is cranial nerve 4, that is lies outside the muscle cone, and it is almost never affected by the retrobulbar block. And peribulbar block, because happens outside the cone, so they block the this fourth nerve. So these are the few the types of the ocular anesthesia. After coming to the clinical anatomy, that is local and general. Of course, general, there is an indication that but we are dealing with the local one. Local means there is a topical anesthesia, intracameral anesthesia, infiltration, and nerve blocks, that is facial and frontal. Then comes the, in infiltration block, there comes the retrobulbar block, peribulbar block, subtenon, and subconjunctival. So these are the, basically how it is given. There is a peribulbar block, and subtenon will come to the block one by one. So general anesthesia is indication is that when the patient refuses local anesthesia, or the patient is a child, or there is having some kind of the movement disorder, or when the surgery is major or the lengthy procedures. So there we prefer the general anesthesia, and there are few limitations with the general anesthesia. That is, there is a challenge if we decide at the age extremities, or comorbidities are there, or patient has to be kept nilperorally for 6 hours, because most of the eye centers are daycare center, except the hospitals one. So regional anesthesia, we have told the principle that it has to have a good echinacea, anesthesia, and analgesia. So topical anesthesia usually causes no physiological disturbance. It is the most economical one, ideal for the daycare procedure. And of course, all those side effects of the hemorrhage, anesthesia, optic nerve damage, glove perforation, they are avoided. But there are few limitations for this. That is, the risk of the drug allergy is always there in any kind of the drug. And analgesia is almost minimal in such cases. Echinacea is not there. And superficial anesthesia is usually, it is not applicable for lengthy surgeries. And of course, in this, the most important thing that the patient's cooperation is required. Then comes the retrobulbar block. It was given by the Herman Knapp in 1884. It is basically the regional anesthesia, which is commonly used since the dates back, and it provides a good echinacea anesthesia. Here we inject the local anesthesia into the retrobulbar space, where we block the ciliary nerves, ciliary ganglion, and the motor nerves. So these are the indications. Before these new modifications of the block came, almost all surgeries were done under this retrobulbar block. Especially ECCs were done, and these days also scleral fixated IOL, or where the surgeon desires that I want some kind of the good anesthesia in these cases. Vitrectomy, of course, retinal surgeries, glaucoma surgeries, keratoplasty, or where we want motionless eye. So these are the few contraindications, that is absolute contraindication, that the patient doesn't want retrobulbar block, or there is some kind of the local anesthesia allergy, local infection is there, patient is having nystagmus, the frequent movement will not allow you to give block, or communication difficulties, postural difficulties, or it is a case of the trauma. There are again relative indication where it is the optional one, that if it is a open ocular trauma, if less trauma is there, we can decide, but if the trauma is severe, we should avoid it. Intraorbital vascular tumor are there, scleral buckling, or especially this high myopic eye where the axial length is more than 26 mm. posterior myopic staphylomas all there, orbital this thyroid ophthalmopathies, bleeding diastasis, anticoagulant use, strong orthopnea, patient cannot lie down, or poor control of the psychiatric disorder. So monocular, especially in these cases, we should not take any kind of charge. So it is given in the retrobulbar space, which is located behind the globe within the muscle cone, and which is formed by the rectus muscle. So these are the nerves which are blocked, except trochlear. Almost all nerves are blocked, and it gives a good anesthesia and echinacea. The drug used in this retrobulbar block is lidocaine 2%, which gives you the rapid onset, and then bupivacaine, which maintains the block. And when these are two combined, and onset of the anesthesia or the effect is within 5 to 10 minutes, and the effect lasts for 1 to 3 hours. So duration of analgesia even after the surgery is 4 to 6 hours. That is why it is a preferred block. And if we combine with hyaluronidase, it enhances the diffusion and the onset of the speed of the onset. In such cases, if at all, we can, the use of epinephrine can be avoided, so that the ciliary or ophthalmic artery spasm avoided and permanent loss should not happen. So how it is, there are 3 agents. We prepare the block, that is lidocaine, we take into, it comes into 30 ml bottle, and then dose is 3 mg per kg, and it is having methylparaben as the preservative. Then bupivacaine, it comes in a 20 ml vial, and again the preservative methylparaben. Then hyaluronidase, it is the vial is 1500 international unit, dose is 50 international unit per ml. So powdered form hyaluronidase is made with 1 ml lignocaine is put into that, and then taken out, the solution is taken out from the this hyaluronidase and mixed with bupivacaine, the lidocaine. Additive, of course, we have already said that epinephrine can be avoided or should be avoided, but if at all taken, the concentration should not be more than 1 into 1 lakh. And the major advantage is it reduces bleeding and prolong the anesthesia period. So another anesthetic agent that these are beside this lignocaine and bupivacaine, there are ropivacaine and levobupivacaine, but they are very long acting, and usually at least I have not used in my 30 years of the practice. So another agent is 2% lignocaine with prilocaine. So it is a very short acting. So lignocaine limitations are there, that the duration of action is around 2 hours, but it is elongated with the bupivacaine. And systemic toxicity, if it is there or injected wrongly, that can cause dizziness, seizures, or arrhythmias also. So we should give with without epinephrine around 3 to 4.5 mg per kg, or with epinephrine we can go with 7 mg. So these are the other agents, that is bupivacaine. If it is again to be taken care of, there can be marked cardiotoxicity due to its strong sodium channel binding and slow dissociation. And another thing is, again, if injected wrongly, it is neurotoxic. Ropivacaine, again, it is a 2 to 3 hours action and better pain control. Levobupivacaine is less systemic toxicity, and prilocaine is given for the fastest onset. So again, everybody knows that how the patient is prepared. Proper pre-operative assessment has to be taken care of, medical history, physical examination, of course, so that there is no contraindication of the block. All those factors are ruled out of the comorbidity, and patient had immobilization, draping, that is to be done. So use of the medication, that you take proper aseptic precautions and then load the drug into it. Then you have to look into all those contraindicated factors that you have to rule out. So pre-operative assessment has to be done. And of course, the another thing is that since it is you need the cooperation of the patient, you have to explain to the patient that we are going to do this. So you please cooperate and look straight. So that is of utmost importance. If you can't tell the patient, then there can be problem while giving injection. Make the patient lie in supine position with the head rest, and by putting povidone iodine, prepare the cul-de-sac and then drape the patient. So this is how the block is given, that the patient lies supine with the eye in the primary gaze. Needle of around 3.0 mm, that is 35 centimeter long, is used, and at the lateral 1/3 and medial 2/3 of the inferior orbital ledge is chosen. Then we take the needle posteriorly parallel to the orbital floor and then at an angle of the 15 degree. After passing the globe, or there will be click or there will be sound, we pass the equator. Then we have to redirect the needle medially and superiorly. Of course, that the feel is altered once we enter the intermuscular septum. Then aspiration is done to check any arterial puncture or any blood into the needle. Then, of course, 1 to 1.5 ml of local anesthesia, which was taken in the syringe, is injected. And then the gentle massage is given. So gentle massage is given to perform to help the spread of the anesthetic agent evenly around the orbit and to reduce the intraocular pressure and improve akinesia. We have to wait for 1 to 2 minutes after the injection so that the proper diffusion is there. Then we close the lids gently and press a sterile gauze or iPad onto it, and then use a gentle digital massage or super pinky balloon is applied. In these cases, after giving a retrobarbal block, additional facial block is also required. So another thing is that we should not give digital massage forcefully, because if you give firm digital massage, pressure can be up to 400 millimeter of mercury. So that is why the firm or very, very deep digital massage is avoided. And of course, the digital massage has to be intermittent. Then this super pinky ball is applied, which sets the pressure at around 30 mm of the pressure, so the structure are not damaged. Then we check for the softening of the globe and proper akinesia. And of course, if the globe is feeling softer and patient is not moving the eye, effect is good. Then don't massage. Another thing over here is that it is not like that you have given the block and you straightforwardly start the massage. Look for the signs of the globe perforation, or if there is the patient of high myopia or staphloma where there is a chance of thin sclera, you should avoid deep massage. Or if there is a pain, very severe pain, or retrobulbar hemorrhage. So these are the advantage of the retrobulbar block, that is good akinesia, anesthesia, and of course analgesia is there and rapid onset is there. So these are the few complications. Retrobulbar hemorrhage can be there, globe perforation, especially myopic eye, optic nerve damage, if you injected wrongly, brainstem anesthesia. These are two important reflexes, that is oculocardiac reflex and oculorespiratory reflex. One should have a watch on this, patient should be on the monitor. And so coming to the complication one by one, that is retrobulbar hemorrhage, that the incidence is around 1%. And these are the factors, that is elderly age. Of course, we are giving to the elderly age. Patient is on aspirin or anticoagulants. So once there is a suspicion of the retrobulbar hemorrhage, there will be tight eyelids, there will be proptosis or subconjunctival hemorrhage or sharp increase in the intraocular pressure. So we should monitor CRA pulsation due to risk of the occlusion also. As soon as we suspect this, we should administer intravenous mannitol and postpone the surgery immediately. So retrobulbar hemorrhage diagnosed, signs of the visual compromise is there, or there are no signs of the visual compromise. If you think, then we can go for the conservative management. If there is a visual compromise, that is lateral canthotomy to be done, and medical management is to be started immediately. Another important complication, the globe perforation. So it can happen in the peribulbar and retrobulbar both, but chances of this is retrobulbar block is more. Again, incidence is, various literature says it varies in different literatures, starting from 1 to 874 to 1 in 16,000. So it is the higher in the eyes which are long and thin, and of course the myopic eye where the eyes are more than 26 mm. Patient with myopia are there, and another risk factors are that, of course, the staphylococcus, enophthalmos, faulty injection technique, lack of awareness of the risk factors, uncooperative patient, or bleeding diastasis or space occupying lesion. So, if sometimes we are unaware of the axial length or we cannot estimate, so looking at the patient's spectacles, we can have an idea. So pain, sudden vision loss, hypotony, or poor red reflex. This should give you the immediate attention. And in these cases, how to avoid this is that you should ask the patient to maintain primary gaze, straight needle, and myopic eyes is there, then we can take smaller needle, and don't inject if there is a resistance is felt. And these are the few things which should be monitored. So management is that it has to be timely one, immediate one, and conservative told if the small perforation or small thing is there, we should observe, but we should not leave and take the retina opinion. And if we think that the perforation is large, or we are sure that we have gone far ahead, then of course immediately should be consulting the retinal surgeon. Then penetration of the optic nerve sheath, the chances are not there that much, but injection technique is always fault. So symptoms usually that comes within 8 to 10 minutes, or sometimes immediately also. Patient will start drowsiness, vomiting, convulsions, or cardiac arrest also. So another thing is myotoxicity in retrobulbar block. Inferior rectus is the most commonly affected, but usually the patient recovers. It is because of the higher concentration. Another thing is which requires our attention is oculocardiac reflex or the Asner reflex. So it is a trigeminal vagal reflex which results in the bradycardia, and bradycardia is such that the normal beat 20% remains. Baseline beat was 80, so the patient will have around 16 to 20 beats. So in that cases, there can be arrhythmias, and it is more severe in children and usually encountered in strabismus surgery. This is the pathway of this oculocardiac reflex, and it goes from afferent pathway to the trigeminal ganglion, then through the vagus nerve, that is efferent pathway, it affects the heart and it causes bradycardia. So what triggers is the pressure or the traction on the extraocular muscle, pressure on the eyeball, or the forceful retrobulbar block or ocular trauma also, and sudden increase in the intraocular pressure. So I told already that there will be bradycardia and asystole. So how we manage this? That we should immediately stop the cessation. Suppose we were pulling the muscle, we should relax the muscle. And of course, the senior surgeon or the OT in charge should be informed, and anesthetist should ensure the airways oxygenation. Anticholinergic agents, they are given, that is by the anesthetist also. And suppose it is a single practice or small setup, we should have an atropine side by side. So that is to be given. So in these cases, if the anesthetic is available, that the anesthesia is deepened or sedation is given so that the reflex stimulation is reduced. So that is how we can avoid, but it is life-threatening also, and we should be very well aware of this. And either the patient should be on the monitor whatsoever surgery we do, or at least someone have a feel of the pulse. Another thing is optic nerve atrophy, but it is a late effect and it is not immediate one. So central spread, that is the leak of the anesthesia into it. So early and prompt response that comes out within 8 to 10 minutes, oxygen is to be given, and we have to maintain the vitals. Another important reflex is the ocular respiratory reflex. The same afferent effect is there, but here the efferent pathway is different, and it goes to the pons and medulla. Again, it happens in the strabismus surgery. So these are the few complications we should be avoided. That is important one are oculocardiac reflex and vasovagal reaction. And of course, there can be so many things that patient can have seizure on the table also, patient can have a cardiac arrest also. And of course, another thing is allergic reaction. So all these things should be, surgeon should be very well, should take care of these things and should be very well aware of these complications. Another block is perivertebral block, which was given by the Davis and Mandel in 1986. So think that this block came after around 100 years of the retrovertebral block. But it is safe one, and it is given around the orbit into the extracorneal space. And again, the primary site is the inferotemporal injection. The patient's gaze is maintained in the primary gaze, and at the junction of the lateral 1/3 and 2/3 is given and parallel to the orbital floor. And again, the important thing is to, once we have injected the needle, we have to aspirate so that we are not there in any intravascular injection. And here the volume injected around 5 to 7 ml of the mixture of the xylocaine and bupivacaine. Another option is, if the effect is less, we can give medial canthus injection to supplement one. And the block required is around 3 to 4 ml. Then in these blocks, how do we assess that the effect is proper? The first sign is ptosis, then comes the akinesia. We check the akinesia by asking the patient to look in all direction. We check the anesthesia by touching the conjunctiva, and of course we can always supplement the perivertebral block. There is another term that is called as modern perivertebral block. So modern perivertebral block, that we have shift the technique to the single injection, and that is again infratemporal, and volume is again 5 to 7 ml, and faster onset is there. So here the reduced risk of the chemosis, lid edema, and IOP is not there because the less volume injected. What advantage of the perivertebral block is there with the retrovertebral block? That we avoid so many complications. Number one is globe perforation, unless and until we do knowingly. And of course, the brainstem anesthesia is not there. We are not going deep. Optic nerve is not damaged. We are not going deep. High myopia, it is safer one with a smaller needle, better diffusion. And of course, easier for the residents where they are beginning their, giving practice into blocks, and of course, effective in complex or scar orbit. This is the few disadvantages. That is, it is a slower onset. Takes around 10 to 20 minutes to achieve the full anesthesia or the full effect. We require the large volume, and more supplementation may be required. So sometimes there can be less predictable akinesia or increased intraocular orbital pressure, or mild postoperative swelling can be there because of the ecchymosis and all that into the subcutaneous tissue. So that is more of the cosmetic problem. So another consideration over here is anatomical consideration, Tenon's capsule and subtenon space for the subtenon block. And it is the globe is surrounded by the tenon capsule. So the space around this, the potential space is episcleral space, where the subtenon injection is given, and it expands like, when the fluid is injected into it, and there is no structure into this. So the tenon capsule fuses with the sclera around 2 millimeters behind the limbus. So subtenon or episcleral nerve block is very good. And, it came late into 1990s, 96 or 95. And here it is, the block is given to the potential space between the tenon capsule and the sclera. So almost any quadrant it can be given, but again, infranasal conjunctival fornix is the most popular around between the 4 o'clock, 4 to 7, to avoid the encountering the insertion of the medial rectus and inferior oblique. This is how the block is given. By putting the local drops, we inject a special cannula, and that is subtenon cannula. By giving a nick into the conjunctiva, we go with the cannula into the subtenon space. So this cannula is of 19 gauge or around 25 mm with a flat or curved tip. The tip is not sharp, which is attached to the syringe, which is filled with the anesthetic agent, and the injection is injected posterior to the equator of the globe. Around 3 ml almost usually sufficient, and it is a good kinesia and anesthesia. So subtenon, because the cannula is blunt, so there are very, very minimal chances of the perforation or hemorrhage, and it is said that it is the least painful injection. The only thing is that chemosis or subconjunctival hemorrhage is higher, and nerve blocks, there are, it is established and popular technique, which was used till 2005 or so. Before this hero came, that is topical anesthesia, and it has become, almost in a daycare clinic or by supervised surgeon, or where the patient doesn't want to stay into the hospital. This topical anesthesia has taken almost all space, especially for the phaco surgeon. And here we give 0.5% proparacaine drop into the cul-de-sac just 5 to 10 minutes before the surgery. And almost all side effects are avoided, except one thing, that there can be corneal epithelial damage. So how it works, that it blocks the superficial nerves in the cornea and conjunctiva only, doesn't go deep, but a kinesia is not there. So you have to have a very cooperative patient, or you have to have a good control with few instruments over the globe. And of course, the post-operative pain can be there, and there you have to supplement with some kind of the analgesic medicine. So this procedure, topical anesthesia, is usually mainly for cataract procedures, and these are the drops. Proparacaine is mainly used. Then another came is the lidocaine gel. Here we, wet the wick with the gel lidocaine and put into the cul-de-sac for 5 minutes before the surgery, and effect is good. So that is how the thing good as far as the outcome on the first operative day is concerned. Eye is quiet, and there is no sign of battling in the surgery room. Patient as well as surgeon, it is basically market strategy for the topical anesthesia, that we will not give you any kind of injection, will not put in the bandage, and there will not be suture. So that is how the things it has picked up. And advantages, it is non-invasive, it is very fast, comes quickly, and it is good for anticoagulation patients who are on anticoagulation medicine. And it, of course, it allows quick vision. Sometimes the patient, most of the time patient come out with the theater with the goggles on, and that I can see clearly. There are so many, videos on the media. You can see that my patient is so and so, and looking after surgery just hour after this or so. So it is again preferred for the cooperative patient who needs faster visual rehabilitation. Then comes the intracameral anesthesia, where we want to supplement, or the pupil is not dilated, or where the patient is, or surgeon, the patient doesn't want to stay in the hospital for a long, and directly shifted into the theater, put the xylocaine, the paracaine drops, and then we inject into this mixture of the tropicamide, phenylephrine, and lidocaine into the intracameral injection is given, and immediately within seconds the effect comes. So used again for the cataract removal, or again it offers the rapid and effective pain relief during surgery also, where the patient sometimes shares pain, and then we can supplement with the intracameral anesthesia. So advantage is that there will be enhanced comfort, phaco is easy, or rapid recovery. Safety is, there are so many less side effects, and of course avoids the need for a full anesthesia team. But never ever forget the pre-operative checkup of the patient. Again, this intracameral helps in reducing clinical or hospital stay of the patient, but still with this, the long-term results are awaited. So with the retrovertebral block, we have this facial nerve block, 4 blocks, that is Atkinson, Van Lint, O'Brien's, and Nedbank. But usually Van Lint is involved. So near the number 1, that is near the around the lids. Facial nerve block, this is called as 4 blocks, and just to supplement the retrovertebral block and to relax the eyelid muscle for better surgical access or less pain, so that the patient doesn't squeeze during the surgery. And it is a supplement with retrovertebral anesthesia. It gives you the comprehensive anesthesia and proper lid relaxation. It tackles the eyelid muscles while the retrovertebral block targets the deep structure. That is how in combination both these blocks work. So again, I would like to emphasize upon by going on retrovertebral, perivertebral, or intracameral, whatsoever it is, but one should take the clinical significance of the orbital shape into mind and then only start with the blocks. That there are few, like deep set eye. Yeah, there you have to have a safer strategy, so that there are chances of hitting the orbit. So there you need to be careful also. Proptosis, again, you need to take care where the chances of needle insertion is there. Smaller orbit, where there are chances of the damaging the optic nerve or surrounding structures. Long axial length we have already discussed. So in all these patients, where are these exceptions of shape in variation, subtenon block or the modified perivertebral block is safer alternative, and we should devise a strategy by using that. So thank you very much for this. Thank you very much.
Thank you so much, sir. So indeed, it was a complete coverage on ocular anesthesia. I'll ask one question initially. Before that, Dr. Preeti ma'am, do you have any comments?
No, I just wanted to add, it was a wonderful talk, Dr. Indra Mohan. I think
Thank you, ma'am.
It's so extensively and beautifully. He has even covered the allergies, which are very often seen. We get patients referred as orbital cellulitis, but it is actually an allergy to the perivalvular anesthesia. What I want to add is that nerve blocks are also important for you to know how to give nerve blocks, especially in oculoplasty, we use it very often. So how to give a frontal nerve block, infraorbital block, and even for DCRs, we block sphenopalatine as well as so in infratrochlear nerves, supraorbital branches. So nerve blocks are extremely nice for oculoplasty when we are doing eyelid surgeries, when we are doing DCRs, in all these cases. Okay, so maybe that you must read when you talk about anesthesia, and also regarding adrenaline. So we as oculoplasty surgeons use adrenaline a lot for eyelid surgeries. But when we do orbits, we don't like to use it because then the pupil dilates and we cannot monitor the pupil, which is a very important sign for us during orbital surgery. The pupil will dilate when we touch the optic nerve or the optic nerve is damaged. So that is an important point. Another thing is you talked about xylocaine as well as bupivacaine. Important is what we use Prilox for topical anesthesia for all these aesthetic patients. You can numb the skin before giving injections. And also we are using now tranexamic acid we mix along with the xylocaine with adrenaline. It helps in our hemostasis in orbital surgery. Regarding retrobulbar hemorrhage that you were speaking, like when you have a retrobulbar hemorrhage during peribulbar anesthesia, the first thing, even before Dimox, would be to do a canthotomy cantholysis. So it's basically the orbital pressure which is high and you need to release that pressure as soon as possible. So every ophthalmologist should know how to do a canthotomy and cantholysis. So you just cut the lateral canthal area and then go inferiorly, feel the inferior limb of the lateral canthal tendon and release that. Once that pressure is released, the orbit becomes a little loose and that compartment syndrome is abolished. And of course, then you need to give the mannitol and Dianox for the intraocular pressure. I think that's about it. Any other points you want to add, Marian, or any other questions from the audience?
I would like to ask you, Dr. Preeti, how this tranexamic acid is mixed with the this thing?
Yeah, so there are various protocols available. There is no standardized protocol, but generally 2.2 ml in 0.8 ml of xylocaine with adrenaline is what we use for local infiltration whenever we do eyelids.
Okay, it is infiltrated.
You can also give it IV. So IV is generally 500 milligram to 1 gram. We give IV, and even that is a beautiful hemostatic agent.
Yeah, IV, of course, is given to stop the capillary bleed.
That's exactly the function even for local.
Okay.
Even in local infiltration, it's basically the capillary bleed which is arrested with tranexamic acid.
Right.
And even topical application of tranexamic acid is good for dark circles and everything. So it reduces the pigmentation. Tranexamic acid is very widely used in under eye creams now.
Okay. So I do have one question, ma'am. So in ptosis surgeries, we prefer regional blocks. So what is your opinion regarding the difference in the intraoperative upper lid height assessment?
So it's very tricky. Ptosis, we give as little volume as possible. So even infiltration, if you're giving, actually 1 or 2 ml is enough. Maximum, even 1 ml is actually enough to anesthetize the skin and the superficial. And when you go deeper, usually the patient doesn't feel pain unless you're going really high above the retinals or something like that. Regional block, frontal nerve block is good. You must care that you're going towards the bone and not going straight in, because then you will paralyze the levator muscle. Again, you have to go really deep in, because if you're again superficial towards the orbital margin, again, you're going to cause anesthesia of the levator muscle. So it's a very fine line between the volume and also the depth and position of the block that is needed. Okay, and we also give a little block on the lateral and the medial side because your palpebral nerves are lying over there. So if you give a little bit anesthesia there, that also helps in the nerve block. But I think the main stay in ptosis anesthesia is the volume. You give less, you're fine.
Yeah, I think it becomes trickier when we take the patient up for any readjustment in the first 7 to 10 days. So during like if you have a scenario of readjustment, do you prefer regional block as well, ma'am, that time?
Readjustment, I don't block actually. So
Okay.
what happens is, if you just, usually I do readjustments at 1 week time. I give them steroid in the first 1 week, oral steroid, so that the part of edema gets taken care of and you can really assess at the end of 1 week. That time when you just open the eyelid sutures and avoid holding the skin, you can retract using the orbicularis. So if you're just holding the orbicularis, there is no pain. And you just need to adjust the sutures a little bit in the levator. So at that time, patient usually does not get pain. They are very comfortable. And I do it actually without any anesthesia.
True. Yeah. Dr. Santosh Anawal sir also does the same. So I just wanted to ask.
Yeah, you can't take them up again. So
right.
usually if you don't touch the skin, they are fine. You cannot touch the skin and retract. That's the problem.
You do supplement it with topical anesthesia at that time?
Topical I give for all patients. When they're shifted inside the OR itself, they get topical.
Okay. All right. So, Dr. Roshni, ma'am, do you have any comments regarding the last talk on ocular anesthesia?
Okay, so the interesting thing here is how important anesthesia is, because while you're operating, once the patient comes out of the surgery, the first thing they judge you on is how comfortable they were. So anesthesia is something so absolutely essential. And we must appreciate Dr. Rastogi for the very, very comprehensive talk. And we need to remember it's a combination of our knowledge of pharmacology and anatomy, which works here. So I think he's given a very marvelous overview. Just a short, a very brief question to Dr. Rastogi. Nowadays, since the topical anesthesia is becoming more and more prevalent, how would you, kind of give a starting surgeon the groundings into ocular anesthesia? How do you tell them that, okay, these are the steps, please start off this way?
Ma'am, let me be very frank. This art of giving retrobulbar or peribulbar block, especially in the cataract theater, is vanishing away. People are, with fancy that line.
How to start off? Supposing there's
for my postgraduate, for my postgraduate, I give them block, make them comfortable, and I ask them to get ready as they are starting for the surgery with the same thing, same sterility, same gown, everything. And first of all, they have to know the medication also. They should usually I start with 3 to 4 talks on the this anesthesia before giving them any kind of the block in the theater. So first they should know what and where they are giving and how to they have to give. And then only I give them the peribulbar block.
I have a question, Roshni ma'am. One thing that I would like to add that I remember an incident where it was in San Diego when the patient was undergoing anesthesia and for blepharoplasty, and when she woke up, she just simply said the first line, "I think I was in Hawaii." I probably it was the effect of anesthesia, but she's like, "I love the surgery. I was in Hawaii for some reason." And I think that adds to the, the post-operative outcome, and it makes them feel better. Now, my question to Roshni ma'am is that for an oculoplasty surgeries, do you think, except for the fact when you really need the ptosis measurement and you need their cooperation, do you think that having all the patients under a minimal anesthesia is a better option than not?
Minimal anesthesia, by
Means
that, do you mean
sedation.
What do you mean?
Minimal anesthesia means like plain sedation, but not like deep sedation, like superficial sedation.
Okay, so one of the things that as you do more and more surgery, I'm sure you're noticing that anxiety plays a major role. Patients, even if they're apparently, very confident, they're not anxious, you will see once they're on the table, especially those of us who have continuous monitoring available, you'll see that their blood pressure spikes, their heart rate increases. And so particularly in oculoplastic surgery, you do tend to get more bleeding there. So along with the local block or infiltration, a certain amount of sedation is absolutely mandatory.
Okay.
Start off with anxiolytics anyway, alprazolam anyway for all surgeries, unless there's some major contraindication. Beyond that, to the extent possible, as you said, I would prefer to have some amount of sedation, unless we need to look at the eyelid movement, or unless it's really a minor procedure.
Correct. So, I mean, like as for example, in cataract surgeries, we need absolutely topical and we are okay. But the extreme in oculoplasty surgeries, it's okay to also sedate. Yes, Preeti ma'am.
Yeah,
What would you say?
I think there is a concept of controlled sedation. When you use pumps to give the anesthesia, they can really control it very well, the anesthetist. So some of the multi-specialty hospitals where I operate, they have the where you can really control it. You can get them in and out of sedation very quickly. And in those cases, but still, I would not use that for ptosis because they are still a little bit drowsy. If you just want to check a muscle action or something like that, ask them to move the eyelid and confirm the muscle and all, that's fine. But if you want to check the lid height, it's very difficult. Sometimes they are so sedated that they are not able to open comfortably. But controlled anesthesia is beautiful for oculoplasty.
Right. And I would say whether it's an educated patient or uneducated patient, anxiety can happen to anyone. And ma'am has correctly pointed that they land up being hypertensive and it just bleeds, and you don't want your field to bleed at all. So I think this has to be kept in mind when we are doing oculoplasty surgeries, that you should have a pre-anesthetic checkup done for all your patients, and you should have anesthesia on the side, and that's okay. You're kind of nearly towards the general surgery aspect. Yes. Farnaz, do you want to ask anything else?
Yeah. So pertaining to the anticoagulants which the patients are, if we do not have an anesthetist in our setup and only ocular, like we do peribulbar and retrobulbar and regional blocks. So how long do you prefer stopping off the anticoagulants pertaining to aspirin, cloplet? And if the patient is on warfarin also, do you suggest bridging? Like, how do we do it when we go, from outside of an institute setup?
So it depends on the condition for which the patient is on an anticoagulant. So usually I like to talk to the cardiologist myself. If it is just an eyelid procedure, then in fact, many a times, even if you don't stop anticoagulants, it's fine for eyelid, but not for orbit. I usually stop 3 days before aspirin and as well as clopidogrel, and we put them on heparin only if they are in a condition where we cannot stop the anticoagulants, and the cardiologist gives us the regimen as to how we need to transition them, and I restart them again 3 days after surgery. But there are many protocols. If you look at literature, there are some people who say minimum 7 days is needed for the aspirin to stop acting. But it's not practically possible in many patients because they are from out of station and this that. So 3 days I think is minimum. And converting to heparin is really very rare. Only if they have very serious condition where we can't stop it. But it's a good idea to talk to the cardiologist yourself instead of just sending in a letter, and there's a lot of confusion then. That's what I do.
Okay, so the point there, the cardiologist, of course, helps us, tell them how long it is safe to stop the anticoagulants. Whereas for the antiplatelets, particularly, we know that the half-life of the platelets, it is the regeneration of platelets is 10 days. So on a rule of thumb, for every day you stop the antiplatelet, 10% of the action is recovered. So, 3 days or 5 days stopping of aspirin, mentally be prepared for the bleeding. This is what I would say to all the aspiring surgeons.
Okay.
It doesn't go off fully, but it reduces quite a bit.
It reduces, but like 5 days you've stopped the aspirin, you expect that its action has been taken care about 50%. The rest 50%, it's still acting.
Okay. So I think based on the surgical time and the complexity of the surgery, we have to.
So
Yes.
that is where everything else comes in. The use of tranexamic acid, the use of hypotensive anesthesia, everything else has to come in at the same time.
Yes, Arundhati ma'am.
Yeah, can I add one point?
Yeah,
So
Dr.
according to the new guidelines by the medicine people, we can stop, there is no need to stop aspirin, but clopidogrel, we have to stop 3 to 5 days. I prefer to stop clopidogrel to stop 5 days before the surgery, especially if I'm doing the oculoplasty. For cataract surgery, yes, we can stop for 3 days, but aspirin we can continue. This is a new regime.
But I think
That's
yeah.
baby aspirin, ma'am, probably.
Yeah, daily aspirin.
No, ma'am, the low dose aspirin
75.
can be
Yeah,
continued.
low dose aspirin.
Yes.
Yes.
But I think when we are giving aspirin and all that, I prefer not stopping it but doing it under topical anesthesia.
Yeah, for eyelids, actually, if you see literature, it's you can do surgery with antiplatelets, but orbits we cannot.
Yeah.
All right. Thank you so much. So moving on to the next lecture and the final lecture of the day, I invite Dr. Arundhati ma'am to talk on entropion.
Can you see my slides?
Yes, ma'am.
Yeah, and I'm audible, right?
Yeah.
Just a minute. Yeah. So, thank you so much, Guru Sangam. Wait, you have to see my slides.
Yeah, that's fine, ma'am.
Yeah, thank you so much, Guru Sangam team, Dr. Santosh Honawar, AIOS, Dr. Preeti ma'am, for this wonderful talk and this session and giving me this opportunity. So I'm Dr. Arundhati Pandey, working as HOD professor in Pune. So I'll be talking about anatomy of lead, entropion, sign and symptoms, types of entropion, what are the differentials, medical management and surgical management. I'm skipping this because Dr. Maria ma'am she took this session very nicely. I'm just skipping this few slides. Anatomy, the orbicularis oculi, because this is again a repeat session. Okay. So what is entropion? As we know, it is an inward rotation of eyelid. So what are the sign symptoms? Ocular foreign body sensation, secondary blepharospasm, watering, ocular discharge, conjunctival metaplasia, superficial keratopathy, because the eyelids are rubbing to the cornea, so it damages cornea, and corneal scarring. So multifactorial pathogenicity, it include tarsotendinous instability, tarsoligamentous laxity, capsulopalpebral fascia dysfunction. Most common is a preseptal orbicularis muscle override, axial position of globe, if it is inside or enophthalmos like that, and tarsoconjunctival foreshortening. What are the types? Congenital, involutional, spastic, cicatricial, marginal. So it is congenital entropion. It is rare. It is abnormal insertion of lower lid retractors. So horizontal tarsal kink syndrome is a rare form of congenital upper lid entropion. In this right-angled inward rotation of tarsal margin causes constant opposition of eyelid margin to ocular surface. So it causes keratopathy. Surgical role, what we are going to do or what is the treatment? Tarsal eversion sutures, transverse blepharotomy, resection of tarsal kink with eversion sutures. So yeah, picture of congenital entropion. What is a involutional entropion? So main predisposing factors are horizontal lid laxity, so increased laxity allows lid to move away from eyeball. Then disinsertion of lower lid retractor, that is the main pathophysiology. Lower lid retractors pulls the lower edge of tarsus inferiorly and posteriorly, and this preventing in turning of lid margin. Laxity of it allows lid margin to evert. Overriding of preseptal over pretarsal orbicularis muscle. So how do we diagnose? Is a pinch test. So anterior pinch test, then to rule out a medial laxity, we pull the lower medial side anteriorly and the lateral side again anteriorly. So lateral pulling and the medial pulling, and the anterior is a pinch test. Signs used for accessing lower lid retractor laxity: higher lower lid eyelid resting position primary gaze, increased passive vertical distraction of lower lid, increased depth of inferior fornix, appearance of subconjunctival white band in inferior fornix, lack of downward movement of lower lid in down gaze. So factors causing involutional entropion are laxity of lower lid retractors, horizontal lid laxity, and overriding preseptal orbicularis muscle. This picture is showing a pinch test. So what are the corrective procedures? So vertical skin muscle shortening, that is Ziegler cautery. Horizontal tightening of lid at lower tarsal border, that is called as the big procedure or Fox procedure. Barricading of orbicularis fibers, that is Wiss procedure and Jones procedure. Tightening of orbicularis fibers, that is Wheeler's procedure. Reattachment of inferior retractors, that is a Jones procedure. So I had a case of this 60-year male. He was having a lower lid entropion. So what is done is a Wiss procedure. In this, transverse blepharotomy and marginal rotation. And transverse lid split prevents upward movement of pretarsal orbicularis. And everting suture shortens the retractors. So after the preparing the patient for the OT, I give generally local anesthesia. And after making a subciliary incision, identification of lower lid retractor is very important. So how do I identify is this is the 5 white thickened band, and when I ask the patient to look up, then I feel the tucking. That is the identification of a lower lid retractors. Then dissect the retractor of the conjunctiva. Advance the lower lid retractor onto the tarsus. So everting, I will be showing video in after few slides. So lower lid retractors are tucked to the tarsus, and they cause skin is again closed. So this was the picture. You can see there is a hematoma and mild ectropion. So for this, wet and wash and vitamin C is given. And you can see gradually that ectropion went away and he had a good normal position of lid. Then again, another picture of Weiss technique, 70-year-old male presented with a right eye lower lid entropion, and this Weiss technique done, and results are very nice with this technique. One more picture, this patient had a bilateral entropion, so I operated in the same setting actually with the patient consent. This edema you can see this edema is because of the local block actually, but it went away within 1 week. So so this gentleman, 70-year-old male, presented with a right eye mild involutional entropion, and left eye he operated 2 years back. In this, the Jones technique has done. So what is the principle of Jones technique? Plication of inferior retractors. Shortening of retractors to create a barrier to upward movement of preseptal orbicularis. So after preparation of patient, horizontal skin incision, it is deepened to muscle, orbicularis muscle. Conjunctiva is not open, lower lid retractor identified, and it is sutured with a 6-0 vicryl to tarsus. So we can do some modification like skin, lid margin, tarsus, lower lid retractors, and skin suture done together. But I prefer to do the retractors and the tarsus and then take a skin suturing. So in 2 layers, I prefer to do closure of this procedure. So yeah, Jones technique, again, you can see there is a good reattachment. You can see a tear film also, post-operative 2 weeks. So this lady, 50-year-old lady, right eye involutional entropion, and this is a post-op picture. So what is a cicatricial entropion? It is caused by shortening of posterior lamella, which pulls the eyelid margin inward. So common cause is trachoma, ocular cicatricial pemphigoid, chemical burns, surgical or accidental trauma, Stevens-Johnson syndrome, recurrent chalasia or blepharitis. So this this 60-year-old male had right eye severe cicatricial entropion with eyelashes rubbing to cornea associated with corneal opacity. So what is done is a marginal rotation of tarsal plate. What is principle? Tarsus is cut by everting eyelid and lower portion is rotated into 180 degree. Posterior lamella is advanced to make a new eyelid margin. So after preparation of patient, eversion of eyelid, incision incise the conjunctiva and upper border of tarsal plate and separate the muscle from it. Suture cut margin tarsal plate to skin with a knot on the skin side. This is very important because otherwise it will cause the rubbing to the cornea. And posterior lamella is preferred than bilamellar tarsal rotation. Marginal rotation of the tarsus, you can see, this poor picture quality, but there was no rubbing of eyelashes to cornea. So this lady, 46-year-old female, she presented with a bilateral mild upper lid entropion, trichosis, dry eyes, query post-trachoma. So what is done in this patient is a tarsal wedge resection. So what is the what is principle? Anterior lamella reposition and lid margin split combined with excision of wedge of tarsal plate. So a simple in the tarsal plate, wedge resection or a small wedge is removed and then it is sutured so that the shortening of the tarsal plate is done. So after preparation of patient, horizontal lid incision. So horizontal lid is around 3 millimeter from the lid margin and tarsal plate exposed by blunt dissection. 2 incisions at 90 degree to each other made at maximum thickness. Superior incision is curved and inferior incision is straight. So that wedge is a wedge shape incision is taken. And wedge of tarsus removed. Skin and tarsus sutured with interrupted sutures. So you can see this post-operatively, she had a good lid approximation. And for trichosis, electrolysis epilation done. For dry eyes, lubricating drops and platelet-rich plasma therapy given. And post-op, she took 3 months because of her irregular follow-ups, but she was perfectly all right after 3 months. So it is a good news. Platelet plasma therapy, I just want one, I added this slide so that it encourage, I just want to have the whole story. So it is an autologous solution comprised of high concentration of platelet and WBC suspended in plasma. It helps in process of tissue regeneration, angiogenesis, epithelialization, proliferation, and differentiation of cells, osteoblast, synthesis of collagen and connective tissue. It decreases inflammation, reduction of pain, and enhance healing. And it made anywhere with centrifugal machine. What is required is ask your pathology friend or your pathology department to get the centrifugal machine, take the patient's blood out, and you can make on an OPD basis. So yeah, coming to spastic entropion. It denotes interning of lid margin which occurs when the lids are in state of spasm after or forceful squeeze. It occurs most commonly after an intraocular surgery, usually anterior segment trauma repair or even routine cataract surgery when eye is irritated or inflamed. These patients usually have coexistent predisposing factor like horizontal laxity. What is cicatricial entropion? Yeah, shortening of the posterior lamella. And we have discussed this. Upper lid entropion is always cicatricial. Common causes are trachoma, chemical burns, post-surgery or trauma, recurrent blepharitis, and cicatrizing conditions like ocular cicatricial pemphigoid or Stevens-Johnson syndrome. What is marginal entropion? It may be perceived as eyelash misdirection. The posterior angle of lid margin has rolled appearance and mucocutaneous junction. It appears to be more anterior than normal. So what are the differentials for entropion? As Dr. Preeti mentioned, the epiblepharon. So a horizontal fold of redundant pretarsal skin and orbicularis muscle, it extends beyond the eyelid margin and it compresses the eyelash against the globe. Usually bilateral, loss of lower eyelid skin crease and overriding of skin fold. Normal rotational orientation of lid tarsal plate distinguishes it from entropion. So generally it resolves with a normal facial growth, so nothing should be done. And for symptomatic cases, reformation of lower lid crease through removal of horizontal skin orbicularis muscle eclipse with a suture fixation to anterior surface of the capsulopalpebral during wound closure is curative. But it is not done very commonly until and unless patients, parents, because it is seen very common in the children. So if the parents are very anxious and they are behind you, no, please do this thing. After explaining everything, if they are still insisting for the surgery, you can give this try. Yeah, this is the epiblepharon. So another differential is trichosis. As we know, cilia rises from their normal lamellar position, but they are misdirected towards ocular surface. Treatment is mechanical epilation. If electrolysis is more effective, radiofrequency ablation, laser photoablation, cryotherapy to posterior eyelid lamella, anterior eyelid lamellar resection, and surgical excision of eyelash bulbs. So preoperatively, how will you assess? Assessment of capsulopalpebral facial laxity, as I mentioned by the pinch test. Assessment of horizontal lid laxity. Enhancement of distraction of eyelid from the globe. Assessment of enophthalmos, it is very important. Sometimes exophthalmometry is done. Assessment of preseptal orbicularis muscle override. Assessment of posterior lamellar support, vertical height of a tarsal plate, we have to measure that, and presence of cicatrizing conjunctival disease, and assessment of marked orbital fat prolapse. So what is done for entropion? We have to think about a non-surgical management first. So if it is a mild and not rubbing the eyelashes are not rubbing the cornea and patient is comfortable, even sometimes patient, they don't want any kind of surgery, then we can try artificial tear drops, lubricating ointments, bandage contact lenses, lower lid taping if the patient is very debilitating or all anesthesia are contraindicated. Chemodenervation of orbicularis with botulinum toxin. It is noted within 3 to 5 days of administration and effect lasts for 3 to 6 months. Towards specific invoking stimulus like trichosis, we have to treat trichosis, blepharitis, and dry eye. What is the role of a surgical management? So quick cut, Rathbun, everting sutures, not done very commonly, but okay. So entropion comes as a short note or a long case or a long question. So you should know all this technique, especially for PG students. Lower lid retractor advancement with a lateral tarsal strip procedure. Then lower lid retractor advancement with lower lid wedge resection. Cicatricical is a retractor advancement, as I mentioned before with the patient. Tarsal plate fracture, posterior lamellar grafting, and if it is a congenital entropion, then retractor advancement. Pickard Rathbun sutures, elderly patient with concomitant medical problems for whom surgery is contraindicated. Patient with bleeding diathesis or not willing for a surgery, then IPD patient who refuse or are too ill to undergo surgery. What is done is a double arm 6-0 vicryl suture is passed through the eyelid from inferior fornix to emerge 2 millimeter below the eyelash line, and it is sutured simply. Then so I prefer 6-0 vicryl suture always. So chromic gut, nylon silk suture, they create equivalent scarring, but silk and nylon suture, they causes epithelial ingrowth along a suture tract. So anesthesia, yeah, it is already been discussed. So for orbicularis override or orbicularis override preventing procedure is a Weiss procedure and Jones procedure. Mild difference is there. So yeah, I would like to show you this video of a Jones procedure. So after giving a local anesthesia, so generally I make the incision 3 millimeter from the eyelash margin. This is the fixation suture is taken. Then cautery is used along the incision, prevents more bleeding. I'm just going deep inside, layer by layer. Be patient, be smooth, and be comfortable. I'm just going slowly. So my assisting sister, she is helping me. Now these are the lower lid retractors. Identification of the lower lid, yeah, tucking. And this is I'm suturing it to the tarsus. Okay, so tucking, and you will see a white fibrous band, thick white fibrous band is identification of the lower lid retractors. Sorry, that inferior part is not seen. So generally I take 3 interrupted sutures. Yeah. So you can see I'm lower lid retractors. One suture is going through and another suture is going through the lower plate or lower edge of the tarsus. I'm suturing it with a 6-0 Vicryl. So I just took the middle, but I did not took a knot. And then middle is first I tie. So I generally take 3 sutures. Middle one is generally I tie in the late or in the last. So this is the corner suture. Again, suturing of the lower lid retractors with the tarsal plate. And if you feel that there is a excessive skin, so generally entropion is associated with excessive skin. So 2 to 4 millimeter skin is again, I prefer to excise for a better cosmetic results. Sandashana Avasa take the whole sutures in one sitting. So these are the simple interrupted sutures. And then and you have to see how much tightening is required on the table, because your lid should not evert. So the suture should not be very tight and not very loose. Again, it can go inside. Okay. And because after giving the local anesthesia, you have to consider the mild edema also post-operatively. So there is an excessive skin. I'm just excising this excessive skin. So middle suture is taken. Interrupted take. Generally, I prefer to have interrupted sutures. And if patient is very young, in 40s, something like that, then I take subcute sutures for better cosmetic results. So this patient was a 65-year-old male. So that is why I'm taking interrupted sutures. Yeah, so all the sutures are done. And post-operatively, I give pressure patch for one day. Next day, I remove the patch. Okay. Yeah. So this is a lower lid retractor advancement. It can be combined with a lateral tarsal strip procedure also, or wedge resection of lower eyelid. So in this, traction sutures are placed, then skin incision 3 millimeter below eyelid margin, extending from just below inferior punctum to lateral aspect of lower eyelid. Then needle is used to dissect through orbicularis, exposing septum, and then muscle is dissected away from the septum. Septum is opened inferiorly with viscous scissor, exposing pre-aponeurotic fat and retractors identified beneath it.
Excuse me, ma'am. I'll just interrupt you for a second.
Yeah, sorry.
Slideshow.
Ma'am, can you take it to the slideshow mode?
Wait.
It was going perfectly fine. I think it moved from that, ma'am.
Wait, ma'am.
Sure, ma'am.
Have to share it again? Or
No, ma'am, just go to the slideshow mode at the bottom. It will be helpful.
Yeah, where you can come down on the panel down, where you have notes after that, that last one, that wine glass shape.
yeah, I got it, ma'am. Yeah.
Just press on that. Yeah.
Yeah, thank you so much, ma'am.
Perfect.
Yeah. Yeah, these are just photos for more clarification. So, lateral tarsal strip procedure. Lateral canthotomy is performed using straight blunt tip scissor up to lateral orbital margin. Inferior crux of lateral canthal tendon is cut. Septum is also freed until eyelid becomes loose. Anterior and posterior lamella, they are split along gray line. Lateral tarsal strip is formed by cutting along the inferior border of tarsus. Lid margin also excised. And tarsal strip drawn to lateral orbital margin and redundant portion is excised. As the suture is pulled up, the loop is tightened. Lateral tarsal strip is drawn against the globe to the posterior direction. And 60 vicryl is passed through gray line at the edges of lateral aspect of upper and lower lid, reforming angle of lateral canthus. Lateral canthus skin wound is closed in layers. So yes, so these are the pictures. So here I'll be doing a canthotomy incision. Okay, posterior tarsal conjunctival layer separate from the anterior musculocutaneous layer. Create this tarsal strip. Okay, and this is actually periosteum and it is sutured. Yeah, so lateral tarsal strip procedure. After giving a local anesthesia, lateral canthotomy is done. I'm just going deep inside to make a tarsal strip. So I'm cutting it with a scissor. This is our tarsal strip. I was just measuring. I was taking the measurement with the caliper, gastromeasure caliper. I'm going anteriorly and the posteriorly. The eyelash margin is removed. I was judging how much tarsal plate is required. Then extra part is removed. I'm just going to the lateral orbital margin till the periosteum. You can see. So this was the periosteum and it is anchored. This tarsal strip is anchored to the periosteum at the lateral orbital margin. Previously, I used to anchor with proline sutures, but now nowadays I find it comfortable with a 60 vicryl also. Instead of proline, we can use a 60 vicryl. I was just checking whether how is the approximation. And this is the lower canthal tendon repair. The eyelid margin I'm suturing. If you use cautery for this lid surgery, it is very comfortable with the patient also and for you also for bleeding purpose. Because eyelid is a very vascular structure, as Dr. Mariam told us, the whole blood supply. Yeah, and the remaining, it is sutured with a skin is sutured with a 6-0 vicryl. And this is a lower lid wedge resection. So what is done is a retractor dissection is carried out in the same manner and freed from conjunctiva. At the junction of lateral 1/3 and medial 2/3, lower lid margin is incised vertically. Edges grasped and overlapped without undue tension. Redundant eyelid cut through tarsus. Then scissors are angulated at 45 degrees to complete wedge resection. And tarsus reapproximated with 6/0 vicryl. Eyelid margin repaired and ends are left long. Vertical skin wound is also closed and lid margin sutures are incorporated into them to prevent corneal rubbing. So these are the pictures of the lower lid wedge resection. Tarsal fracture. Traction suture is placed horizontally through gray line centrally and eyelid everted over a Descemet's retractor. Horizontal incision is made through whole length of tarsus on the posterior surface of the eyelid down to the deep surface of orbicularis. 3 to 4 sutures are passed through tarsus just below the incision and through the eyelid to emerge from skin just below the lash line. And sutures are tied to produce a mild ectropion. So this is the transfer tarsotomy of the posterior lamella. It allows rotation of the marginal eyelid segment. And incision placement preserve the integrity of marginal vascular arcade. While working on the lid, you have to consider, please always remember the marginal vascular arcade, superficial and deep. So posterolamellar graft, it is indicated for the patient with a severe degree of cicatricial entropion with marked eyelid retraction. Hard palate, buccal mucosa, there can be used. Tarsal plate fracture carried out like before an inferior margin of tarsus is freed from eyelid retractors and orbital septum. Defect is measured and then slightly oversized graft is harvested. Sutures are passed in a partial thickness fashion through hard palate graft and through a full thickness of eyelid. These are tied just below lash line to evert eyelid margins and maintain graft in position. Edges of the graft are sutured to the anterior edge of tarsus superiorly. Again, this explain, the picture explain everything. Complication of entropion, yeah, overcorrection, very common. So this may cause excessive advancement of capsulopalpebral fascia, attachment of fascia too high on anterior tarsal surface, undercorrected horizontal lid laxity, postoperative ectropion, if it is mild and tolerated by patient, conservative management. But if it is severe, then transposition of preseptal orbicularis strip closer to lid margin or full thickness skin grafting. Hematoma, very common. These are usually self-limiting and resolve within periodic warm compress and observation. Vitamin C should be given. Hemorrhages that occur at hard palate donor site originate from a greater palatine or nasopalatine arteries. It can be controlled with digital pressure, submucosal epinephrine injection, electrocautery, cellulose or collagen sponge, or periodontal putty or a palatal stent. Eyelid retraction. It results from excessive horizontal tightening of tarsus or excessive vertical advancement of capsulopalpebral fascia. Exposure keratopathy, again a common complication, not very common complication actually. So corneal epithelial damage can develop from post-op lag ophthalmos, exposed conjunctival sutures, and keratinized hard palate graft. Treatment include ocular surface lubricants, bandage contact lens, and suture removal. Ptosis, aponeurosis ptosis can complicate repair of cicatricial upper lid entropion. The posterior fibers of levator aponeurosis, they attach to inferior one-third of tarsal plates anterior surface. And during posterior torsotomy, it is important to avoid this disrupting these fibers. So thank you so much, everyone. This concludes my talk. I'm grateful.
Thank you so much, Dr. Arundhati ma'am. So before I move on to my questions, I request Dr. Roshni ma'am, if you can give us some comments.
Dr. Arundhati, that was a very, very comprehensive talk on entropion, all the different types and how exactly you tackle each one. Just wanted to add a couple of things. One step before you go to surgery, this is something who does a lot of cataracts as well as oculoplasty will come across. Once in a while, post-operative cataract patients will turn up with entropion.
Yeah.
So they're almost always spastic.
Yeah.
So even without surgery, taping the lower lid out so that the eyelashes don't touch the cornea anymore, or sometimes giving a little bit of botulinum toxin into the pretarsal orbicularis helps to improve it. Because at that point of time, both the surgeon and a patient are in a panic.
Yeah.
So that's another variation of this. The other thing that people miss is when there's an unexpected entropion, looking at the inferior pharyngeal conjunctiva. This is rare, but if there is shortening of the conjunctiva or small symblepharon, that might be a pointer to an ocular cicatricial pemphigoid starting off. So that's a situation where doing a surgery always causes an exacerbation. It's going to make the inflammation flare up even more. These are the two things I'd like to add.
Dr. Preeti ma'am, you would like to add something, please?
A beautiful talk. I think so many videos and we got to see all the procedures really nicely. Thank you so much for that talk. Few things that I wanted to point out is that V's procedure, I personally do not prefer too much because you are cutting through all the lymphatics in the eyelid. Horizontal blepharotomy will sever the lymphatics. So many of these patients come with chronic edema, long-standing edema because of the lymphatic problem. So if you have horizontal lid laxity and if you also have overriding, you can correct that with a lateral tarsal strip and take quick cuts because that will redirect the orbicularis by creating a scar along the track of the quick cut sutures. So that is another way of avoiding V's procedure. Also, when you're examining, it's important to ask the patient to look down. In the downward gaze, the lower eyelid will also move downwards along with the globe. That means your lower lid retractors are okay. That's how you check the lower lid retractor dehiscence. And if there is a dehiscence, you can add a Jones procedure to the whole correction. And in that way, you can avoid a V's. You can do either an LTS with Jones or LTS with a everting suture. The everting suture, though it is temporary, it creates a fibrous tract. And that creates a barrier between the pre-septal and pretarsal orbicularis. Okay. Now, another point was regarding the cicatricial, which Roshni has beautifully pointed out. Many a times we get patients referred for symblepharon. Just you look at the symblepharon and they want it to be corrected. But it does nothing actually. If you have some symblepharon in the fornix, if your patient is not having diplopia, if he is comfortable, it's better not to touch it, especially in Stevens-Johnson's and OCP patients, because that will reactivate the disease. And for cicatricial, the various grafts that you were describing, for the lower eyelid, a little bit stiffness is preferable, so a hard palate graft is quite nice. We see a lot of these cicatricial entropions now because most of us use conjunctival approach for orbits, even post-trauma or for tumors and whatever. And if you don't follow those planes well, will end up having cicatricial entropion. I think that's about regarding suture for lateral tarsal strip. I feel Vicryl suture retains its tensile strength only for 2 weeks, though it gets resorbed by 45 days. If you see, the tensile strength is 2 weeks. Most of the time, you can get fibrous tissue there by that time, and therefore many surgeons use Vicryl. But if you want to use an absorbable PDS, would be a little better because it lasts a little longer. It gets absorbed after a few months. Prolene, of course, is a little problematic. Every patient will tell you that they can feel something here. And it's a good idea to close the orbicularis over that suture. So you do the closure in 2 layers. That in that way, the patient is more comfortable and they don't complain of that annoying irritation at the lateral canthus. And when you redo the canthus, you must avoid a slight ectropion, which sometimes happens if you don't do a gray line to gray line opposition really well. And that small ectropion is also very the patients get very symptomatic because of that. So, and I would prefer 5-0 for the inside strip because it's a little stronger compared to 6-0. But I think it's all a surgeon's choice, but you must know the reason why you're using a certain suture. Anything else? Any other questions?
Yeah. So from a postgraduate point of view, since there are like so many procedures listed for entropion surgery, especially when I was a postgraduate as well, like if you would like to summarize in just, 3 or 4 quick lines, like, okay, so if this clinical feature is present, we'll prefer this surgery. I think most of it is covered, but if you can list it out in just 3-4 lines, it will be great. I mean, it will be of great help for the postgraduates.
Yeah, I think for the PGs, mostly it will be senile, okay? So when you see a senile entropion, you have only 4 things to see. You see overriding of the preceptal over pretarsal. You look for lid laxity. Look for the lower lid retractors, whether they are dehisced or not, okay? These are the 3 things mainly you need to see, and of course, rule out a spastic. So how you rule out a spastic is just put Paracaine on the ocular surface. That will cut off the reflex spasm that the patient is having. With Paracaine, if the spasm goes off, that means it is spastic. Okay. Now, when you have these 3 factors, if you have lower lid laxity, you can do lateral tarsal strip. If you have medial canthal laxity, you tighten the medial canthus. So basically, you tighten the eyelid. If you have an override, then you have to create a scar in between the 2. Okay. So that scar tissue creating, you either do V's, which she has pointed out. Me as a surgeon, I prefer an evertic suture to create that scar. If your lower lid retractors are dehisced, you do a Jones. So senile is quite easy to understand and clear. Okay. Cicatricial, if the patient is not symptomatic with the symblepharon, leave it alone. If the patient has an entropion rubbing with the eyelashes rubbing on the ocular surface, sometimes the eyelashes won't be rubbing. They will be just vertical. That also you need to see on slit lamp well. Okay. So if the patient is symptomatic and if they have cicatricial entropion, if it is very mild, you can do a tarsal rotation. If it is very severe, you need a graft. The way you put a graft and the way you choose a graft, that depends on which eyelid. Okay? Simple, no?
Yeah.
I
Thank you
have a
so much.
question for Indu Mohan Rastagi, sir. So it's a very interesting question. So I know that the first point of contact for any entropion case is probably to you all. So what do you prefer to do? Do you usually refer these cases, or do you prefer to operate on them for entropion cases? Because they mainly present to you directly first.
I do it myself in medical college. Do it myself, and in practice, since my practice is mainly cataract practice, usually these cases don't come. But in medical college, I have done many entropions.
Right, sir.
I usually don't refer, except retina cases. I don't refer anything, whether it's a comprehensive cataract surgery or I would say trauma or pterygium or I would say entropion. anything. I even I do all cases except retina. I don't refer anything.
Right, sir. Okay.
But
And
anybody can do as long as you're comfortable, you're confident, and you can recognize the layers and do the right choice of procedure. Anybody can do it. And
right, and I'm sure that sir has had so many experiences. I think he knows exactly how the different anatomies can
So my
present.
my my practice, I am in medical college also, and my practice also, I have charitable also. So I have done rural practice also. I have done urban practice also. So that I have done 3.5 years senior residency in medical college also. So usually, except retina cases, I don't refer anything of my practice.
I think I'm sure that took a lot of effort, sir, because I'm sure that you had to make sure that you are doing the right thing the right way. So you must have gone into a lot of teaching, or I mean, learning as well. So that's great, sir, because then you're an expert, and it's like a pan ophthalmologist that we're looking.
No, no. Because if for my residents I have got 7 MS students, and if I refer everything, then
Then they
things
cannot
becomes a
see
little
the.
difficult.
And they get to see a variety then.
Yeah.
Right, sir.
sometimes I feel it's a good idea to have a colleague, do 1 or 2 cases with them so that you know how different it can be done also sometimes. Yeah, because everybody's approach is so different, and if you can get 1 or 2 of your colleagues who are doing primarily oculoplasty, you would, get certain different ways of doing the procedures too.
Right. Roshni ma'am, would you like to add some comments to it?
So I would like to congratulate you for putting together this lovely webinar. Particularly, Dr. Arundhati, your videos were very, very clear. They were so to
Thank
the
you, ma'am.
point. They showed all the anatomy so clearly. They're quite to be admired. And they're an excellent teaching tool. Thank you.
Right, ma'am. Thank you, everyone. I think this is like a good Sunday evening, and I think no, it feels like morning for me. But it looks like, we have learned a lot, and this is a good beginning of the oculoplasty sessions. And we have the next entire week of oculoplasty coming up, and we'll be happy to cover the most often asked topics and most often covered topics with all of you. Thank you to the speakers as well as the expert panelists for sparing your time. I know that Sundays are for your free time, so thank you for coming and sharing the screen with us. Thank you, everyone. And thank you for Naz, and thank you, Sunilji, for your support.
Thank you so much,
Thank you,
everyone.
Dr. Preeti. Thank you, Dr.
Wonderful.
Rashmi and Farjan. For nice.
Thank
Thank
you,
you
Dr.
very much.
Preeti and Dr. Rashmi, for great insights. I'm grateful. Thank you.